Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I am your host, Taryn Gross. Today's episode is entitled Respiratory Syncytial Virus in Older Adults, Understanding Risk, Diagnosis, and Evolving Prevention Strategies. During this episode, Dr. Spencer Durham from Auburn, Alabama, Dr. Stefan Gravenstein from Providence, Rhode Island, and Dr. Barbara Resnick from Baltimore, Maryland discuss risk factors for respiratory syncytial virus among adults, the need for a vaccination strategy in this population, and the evolving clinical studies on vaccines for older adults. For more information about our expert faculty and for a link to additional educational content on this program, including downloadable slides, please visit the show notes for this episode and follow along. Now let's get started with the program, beginning with Dr. Gravenstein.
Good afternoon. Thank you. As you heard, I'm from Brown University. I'm professor of medicine and geriatrics here, and I get to talk about sort of the background on RSV illness. So specifically, today we're going to talk about this as a disease and specifically how it affects older adults. You may not know that RSV is actually quite common as an infectious disease, and it causes typically mild cold-like symptoms. And in most cases, people will recover within a couple of weeks. What is often not known is that when they get infected, the oldest people and those with immune compromise take longer to recover, and they can also shed virus longer. We've known about RSV since 1956 when it was first isolated in monkeys, and then they figured out it also infected humans, and that it comes in two major subtypes. This is a para-influenza single-stranded RNA virus, and it comes in types A and B based on the antigens on its surface. It's the third most common viral pathogen after influenza A and B, and in children younger than 1 year of age, it causes bronchiolitis. When children and older adults get infected, they don't actually get long-term, long-lasting immunity from future infections. So they can get infected more than once and year after year. So when you see somebody presenting with RSV, they really don't look any different than any of the other viral infections, whether this is a SARS-CoV-2 infection that is symptomatic or otherwise. When they initially present, they have vague sort of cold-like symptoms. You don't typically get loss of sense of smell or taste, but you can get that with RSV like you do with SARS infections. And because you can't really distinguish it from other infections, to know that it's RSV, you have to do a laboratory test. The most sensitive laboratory test for this and other viral infections is real-time reverse transcriptase polymerase chain reaction, RT-PCR, and that has the highest diagnostic yield. Antigen testing works quite well in children, is less effective in older adults and adults in general, and we don't really use viral cultures for testing for RSV anymore. In the research setting, people like me will use serology as a way to figure out if somebody had been infected with RSV. But if you had an outbreak, say, in a nursing home, serology can be useful to nail down what it was that caused a rapidly spreading respiratory illness, whether it was RSV or flu or something else. Some of these tests that you order can differentiate between RSV subtypes A and B, but that isn't clear whether that gives you a clinical advantage in how you manage them next. So even though we typically think about this as a childhood disease, it poses a serious threat to older adults. In the US, it causes somewhere between 14,000 and 50,000 deaths a year. That's actually in the same ballpark as influenza, which is between 3,000 and 90,000 or so in most years. Hospitalizations, 177,000, and medically attended illnesses, not quite 500,000, and symptomatic illnesses, 1 million. So in the US, the annual attack rate is 2 to 10%. Contrast that with influenza, which is typically 5-10%, sometimes a little higher than that. And in older adults, that live in congregate settings, it's at that same higher range as flu, 5, 10, 15%. In nursing home studies, when we look at influenza outbreaks, a third of them typically will have an outbreak in a typical year, and I suspect that RSV outbreaks are near that number. Compared with their younger adult counterparts, older adults with RSV are much more likely to become hospitalized and die. And this disease burden is expected to increase as our population continues to age. So why is it that they get sicker? It's the same list of conditions that you think of with influenza, with some call out specific to, for example, heart failure, kidney disease, and underlying lung disease, which really drives that risk for hospitalization. So the interconnected factors here on the left is when older people get sick, the symptoms they get are in part driven by how robust the immune response is. We get symptoms, for example, headache and myalgia and chills, not because there's virus in our brain or in our tissues outside of the respiratory tract. We get it because we have an immune response that generates cytokines that are inflammatory markers that they themselves cause the malaise, the myalgias, the fatigue, and the headache, and so forth. So as we get older, we produce less of this. And so typically we will be less symptomatic in older adults when we get infected with things like RSV. Furthermore, chronic diseases and multimorbidities can affect how we present and also how we produce those cytokines. And there's frailty. It's the exposure to healthcare providers that might be infected that can give it to us. Malnutrition can interfere with our immunity. If we get vaccines for things, we typically don't respond as well as older adults to those vaccines. If we get drugs, some drugs dry out our secretions, and that can impair the ability for our mucociliary escalator in the respiratory tract to sweep out the pathogen. And in much the same way, as we get older, the density of cells, those ciliated cells in the trachea and below, goes down and reduces the efficiency of clearing pathogens. So we have less physiologic reserve, and then we might be in settings where there's increased exposure because it's a closed setting with close contact with healthcare workers. Anyhow, these things collectively increase our susceptibility with age, increase the morbidity and mortality, increase the likelihood of being hospitalized in the first place and lengthen the hospital stay, increase the risk because of duration of shedding, of transmission, and ultimately drive healthcare costs. So when somebody gets infected with RSV, like with other viruses, that creates sort of raw tissue culture medium for bacteria. There was a study with 842 winter hospitalizations, of which 41% had a viral etiology. 61% were from viral infections alone, and 18% of these had RSV in those patients confirmed with bacterial superinfections. 90% of them had received antibiotics as part of treatment, even though even though only 40% were, even among the 40%, there were quite a few that got antibiotics. So there are tests you can do to look for bacterial superinfections like urinary antigens for strep pneumonia, cultures and serum procalcitonin. But I think the big message from this slide is that superinfections, bacterial superinfections occur in about 12% of these RSV infections, and it's something you need to keep a lookout for. So this slide is on the risk of developing hospitalization with RSV, and the highlighted things here of really increased risk: COPD, heart failure, hematologic malignancy, stroke, and chronic kidney disease are historical things that if you have those ahead of time, you have a significantly increased risk for being hospitalized with RSV. You'll notice there's some other things that don't reach significance, coronary artery disease, organ transplant, and so forth. Some of that has to do with the sample size to not be able to demonstrate that difference. I know in our studies with influenza vaccine, there's a 15-20% reduction in likelihood of being admitted to the hospital with heart attack if you had a flu vaccine. And I assume that if you could prevent RSV, that you could also get a reduction in those kinds of outcomes, and hopefully also with heart failure, COPD, stroke, and so forth. So I think one of the big lessons is that RSV affects the heart, and it can do things including trigger acute myocardial infarction. The way this works is think about this as a generic infection that produces an inflammatory response. And so in this slide, the example is flu, RSV, bladder infection, shingles. Now, I think the influenza and RSV, I think of this as systemic respiratory tract infections. There was an article published by Smith back in 2005 in the New England Journal where he reported that people who had a systemic respiratory tract infection, or UTI sort of generically, had a 2 to 4-fold increased risk of first ever MI or stroke in the 2 weeks that followed that infection, with a tail that lasted out for 3 months. So in general, these infections which cause inflammation, you get a reduced protein C or S. You can get a variety of other physiologic markers, tachycardia, hypoxia, cytokine release, and so forth, that culminate in plugging of a vessel, a thrombogenic event, or a thromboembolic event that can produce acute myocardial infarction or stroke. And if it's a small MI, maybe all you see is heart failure. So when you think about this, this is now reported by Jeffrey Kwong. Jeffrey Kwong did a series from Toronto. He published this in 2018, where he was looking at the likelihood of being hospitalized following an influenza A, B, RSV, or other respiratory virus infection. And in the week after that infection, you can see, for example, influenza A and B had on average about a 6-fold greater likelihood of being hospitalized with a heart attack. RSV was up there too at 3.5 times more likely, and other respiratory viruses too. So this is a message again about this inflammatory push that ends up putting you in the hospital, in this case with the outcome of AMI. When I talk about the process of this for my house staff, we look at this as a thrombometer, and this is something that I termed to talk about what's the likelihood that you're going to have a clot in one of your blood vessels. So when your inflammatory markers are low, on the left here, low markers of C-reactive protein, interleukin-1, of alpha, as examples, your propensity to clot just physiologically basically is quite low. But if you add to that just purely making them older, those markers all start going up, and you can see the thrombometers clicked up a little bit. And so these markers start increasing just by virtue of getting older. If you add to that diseases, it kicks up even higher. So, for example, in diabetics, you're going to have, the typical diabetic will have a CRP that's greater than 0.01. And if you add to that now infection, flu, RSV, community-acquired pneumonia, shingles, bladder infection, pressure sores, those all kick it up quite high. And then it's sustained high for a period of days or weeks, a little longer with RSV than with flu. But so older adults will have this sustained elevation and thrombogenic potential that persists more than just a few days after the initial infection, and probably even for weeks or months if you believe the data from Smith. So with that, I'm going to shift over to Dr. Durham, who will talk to you about RSV prevention. Dr. Durham?
Thank you so much, Dr. Gravenstein. As Taryn said earlier, my name is Spencer Durham. I'm an associate clinical professor at the Auburn University Harrison School of Pharmacy, and my area of expertise is in the field of infectious diseases. And I did want to mention before I get started with my section that just this week, the CDC actually released a warning that RSV infections throughout the country are increasing, but in particular in the area where I'm at in the South, we've seen a significant increase in RSV infections over the past few weeks. So I think this is a very timely topic. The focus of my portion is going to be talking about vaccines that are associated with RSV. However, I did just want to mention a few general preventative measures, and these are really the same things that you would expect or that we would see with other respiratory viruses like the flu or COVID. Frequent hand washing, using hand sanitizer, avoiding touching your face or coming into very close contact with others who are sick and might have RSV or one of these other viruses. So all of those things that we typically think of for preventing respiratory viral infections hold true with RSV infection. I also wanted to mention that, again, even though we'll be focusing on the vaccines, for the sake of completeness, I wanted to just mention that there is a non-vaccine agent with proven benefit in preventing RSV disease, and that's the monoclonal antibody palivizumab. This is an agent that's used in infants and children, and it has shown pretty good effectiveness when it's used prophylactically. Usually in the pediatric population, it's administered as a monthly injection during typical RSV season. Only in infants and children who have a high risk of complications should they acquire RSV. We're not going to talk about this drug any further simply because it is not, or there's really no evidence that it's useful in adults. Especially in older adults. It's something that's really confined to the pediatric population. So I just wanted to make everyone aware that that drug does exist. It's possible that in the future we might see more evidence in the adult population, but we just don't have that right now. So if we look at specifically vaccine development that's associated with RSV, actually back in the 1960s, there was a lot of efforts to try to create a vaccine against RSV. And in fact, a vaccine was created. It was a formalin inactivated vaccine. And unfortunately, the studies show that it just was not effective in preventing RSV infection. And in fact, children who went on to develop a primary RSV infection after receiving the vaccine actually had more severe disease than children who did not receive the vaccine. And unfortunately, that ultimately resulted in 2 different patients dying. It's not really clear exactly why the effects of that occurred. The thought is that the formalin inactivation may have enhanced type 2 T helper cell immune responses, which resulted in an even further cytokine release, kind of like Dr. Gravenstein was talking about. And it's thought that that may have led to this just overwhelming inflammatory response in those patients that ultimately resulted in their deaths. So I think it's certainly easy to understand why there would have been some stalling in the development of an RSV vaccine after those results from that initial formulation. However, over the past couple of decades or so, we've seen many more efforts in trying to create an RSV vaccine. There are certain obstacles that we would think about specifically to create an RSV vaccine, just some challenges that we might see in just the biochemical behavior of vaccines, and in particular with RSV. And certainly things that we may see in a laboratory setting that might see in an animal model don't always work out well once those vaccines are studied in the human population. So keep those things in mind as we go through some of these other vaccine studies. There are currently at least 17 different RSV vaccines that are undergoing studies in clinical trials. And there are different vaccine formulations that are being investigated in different populations. The 3 primary populations that we're looking at are vaccines for infants and children, vaccines for pregnant females, and then vaccine in older adults. And for the purposes of these trials, we're going to define older adults as greater than 60 years of age. And the reason for that is that some of these vaccine trials, as you'll see, have included patients who are over the age of 65, but some have included patients who are over the age of 60. When we're looking at these different RSV vaccine candidates, they can, generally speaking, be divided into 4 different categories: live attenuated vaccines or chimeric vaccines, protein-based vaccines, which are inactivated, nucleic acid-based vaccines, and then recombinant viral vector vaccines. For our purposes going forward, we're not going to talk about live attenuated vaccines since they are not being studied in the older adult population. And they're probably unlikely to be studied in this population as well, just because we don't, in most cases, give live vaccines to older adults. Even though they typically produced a very robust immune response, the older adult population is more likely to have adverse effects from a live vaccine. So it's probably not likely that these are going to be studied significantly in that particular population. So we'll begin by talking about RSV subunit vaccines. And I just wanted to mention the ones that are on this slide. The first one is called MEDI7510. This was a vaccine that was under development a number of years ago. There was a randomized double-blind placebo-controlled phase 2 trial in about 1,900 patients who were greater than the age of 60 that demonstrated that this vaccine was effective in immunogenicity. So in other words, the participants who received the vaccine produced an antibody response. However, it ultimately just was not effective in actually preventing RSV illness. The incidence of RSV in the vaccine group was about the same as it was in the placebo group. It's not completely understood why that is, why the antibodies that were produced didn't actually protect against RSV infection. But because of those results, this particular vaccine is no longer in development. It's a possibility that we could see some clinical trials on it in the future, but as of right now, nothing is being looked at for this particular product. The other vaccine that I wanted to mention are the F, G, and M antigen vaccines, and these have been evaluated both with and without an adjuvant. For this particular vaccine, there was a randomized placebo-controlled phase 2 trial in patients who were greater than 65 years of age. And these patients had high-risk conditions. So in other words, they were high risk in that if these patients had acquired RSV, they would have been likely to have had a poorer outcome. So that included things like patients with congestive heart failure, like Dr. Gravenstein had talked about previously, COPD, and those sort of things. The results of this trial actually weren't that bad. There were a number of patients who had a really good antibody response. They had a greater than 4-fold increase in neutralizing antibody production. So those results looked promising. However, there had been no further development of this particular vaccine in the past 10 years. So we don't really know if this is something that a company will pick back up and try to look at further. But as of right now, this particular product is not being studied. The next vaccine is also a subunit vaccine. It's called RSV Pre-F3. This is a recombinant subunit vaccine that does contain an adjuvant. The interim results from a phase 1 and 2 study in about 1,000 healthy adults who were aged 60 to 80, so pretty much that otherwise healthy older adult population, demonstrated that the vaccine was very well tolerated in those patients, and it did elicit an appropriately 10-fold increase in the RSV antibody production compared to what was seen at baseline. In actuality, the patients had a CD4 T cell response that was comparable in magnitude to healthy adults who were between 18 and 40 years of age who actually didn't receive the adjuvanted vaccine product. So those results all do look very promising. Again, that's a phase 1 and a phase 2 study, but the results look promising. So there are some phase 3 studies in adults that are being looked at in greater than 60 years of age that are either currently ongoing or are currently planned. And those two are listed on the slides here. In that first trial, that's going to look at safety, reactogenicity, and immunogenicity and long-term immune response. And there's about 1,600 patients planned for that trial. The second trial is going to look at actual efficacy of the vaccine, but I would point out that this is a really big trial. The N is planned as being about 10,000 patients. So certainly we'll be interested to see those results when they come out probably in a few years. The next vaccine that I wanted to talk about is a particle vaccine. It's the RSV-F nanoparticle vaccine. It's a recombinant nanoparticle vaccine with or without an aluminum-based adjuvant. There was a phase 1 trial with this product that looked at adults who were over the age of 60 years, healthy adults over the age of 60 years. In this trial, participants were randomized to receive either a placebo, 60 micrograms of the vaccine, or 90 micrograms of the vaccine. And that was with or without the adjuvant. And all participants also received a trivalent influenza vaccine. With this being a phase 1 trial, they looked at tolerability. And so the vaccine was very well tolerated. There were no significant adverse effects that were reported. The adverse effects were things that you would expect to see with a vaccine, things like injection site reactions and that sort of thing. And you can see on this trial as well, if you look at the antibody responses, they do look pretty good. The antibodies responses clearly were higher in the patients who received the different vaccine products. And so again, that looks very promising, but again, that was a phase 1 trial. There has, however, been a phase 3 trial involving the nanoparticle vaccine. It was called the Resolve trial. This was a randomized, observer-blinded, placebo-controlled phase 3 trial in adults who were over the age of 60. These patients were randomized to receive either the non-adjuvanted vaccine or a placebo product. The non-adjuvanted vaccine was associated with no significant difference in preventing moderate or severe RSV disease, which is their primary endpoint. So that wasn't particularly promising. But interestingly, it was associated with a 61% reduction in hospitalizations due to COPD exacerbations. So if you look at the results of this trial, it wasn't quite what we were hoping for in terms of actually preventing RSV disease. But it was positive enough in the reduction of hospitalizations that probably this does warrant further study. But I would point out that what was studied in this particular Resolve trial was the non-adjuvanted formulation. If you remember back to the previous slide, what was studied in phase 1 trials was both the adjuvant and the non-adjuvant formulation. And the adjuvanted formulation did produce a pretty good antibody response in that trial on the previous slide. And so the adjuvanted formulation probably is worth further study in the older adult population. The next type of vaccine I wanted to look at is an mRNA vaccine, and I'm sure just with COVID, everyone is probably pretty familiar now, or at least have heard of mRNA vaccines. For this vaccine, there was a randomized, partially double-blinded, placebo-controlled dose escalation phase 1 trial that looked at healthy younger adults, so adults between the ages of 18 and 49, and also healthy older adults, those aged 60 to 79 years. The vaccine was well tolerated at all of the doses that were studied, and as you can see on this slide, they did study a number of different doses of the vaccine product. All of the doses did elicit neutralizing antibodies, as well as cell-mediated antibody responses. So certainly those results look promising. Again, it's a phase 1 trial, but it does look promising. So certainly this particular mRNA vaccine does warrant further study in the older adult population. The next vaccine that we'll look at is a viral vector-based vaccine. It's AD26 RSV Pre-F. And this particular product uses an adenovirus, specifically adenovirus serotype 26, as the vehicle for administering the vaccine. And for this trial, there was a randomized, double-blind, placebo-controlled phase 2 trial in healthy adults who were aged 18 to 50 years. These participants were randomized to receive either the vaccine product or placebo, followed by an intranasal challenge with RSV-A 28 days after immunization. And as you can see on the slide here in the graph, the area under the curve for the RSV viral load was significantly lower over time in the vaccine group versus the placebo group. Now, I would point out that if you note the viral load is lower, but in some cases it's not completely gone. So the patients who received the vaccine were still producing some virus, but it was much lower in the vaccinated group than in the placebo group. There was also a phase 1 trial in healthy older adults who were greater than the age of 60. And because of the positive results with these trials, the FDA actually has designated this vaccine product as their breakthrough therapy designation. And there is a phase 3 trial called the Evergreen study that's currently recruiting for the older adult population, or excuse me, I think they'll be recruiting soon. The trial is planned and they will start recruitment very soon. I wanted to also mention this other trial. So this other trial also looks at the AD26 vaccine, but it was combined with the influenza vaccine. So this trial was double-blind, placebo-controlled phase 2A trial that looked at older adults greater than the age of 60. Participants were able to receive one of two different dosing regimens: the vaccine, the RSV vaccine, plus the influenza vaccine on day 1, followed by placebo on day 29. Or they received placebo and the influenza vaccine on day 1, followed by the RSV vaccine on day 29. The results of this show that the vaccine was, again, very well tolerated, no significant adverse effects, just things that we would expect to see with a vaccine like injection site reactions. We also see here from the graphs that the RSV vaccine did elicit a strong immune response as you can see here. And then also the concomitant administration of the influenza vaccine with the RSV vaccine did not affect the immunogenicity of either of the vaccines. I think that's something that's important because if we think about the potential of having an RSV vaccine one day, RSV season certainly does overlap with influenza season. And so you would be likely, or patients would probably be likely to receive the flu vaccine and an RSV vaccine either on the same day or be very close together in time. So it is important to look at would one of those vaccines affect the other? And according to this study, that doesn't seem to be the case. So those results look very promising. And at this point, I will hand the presentation over to Dr. Resnick.
So thank you very much. And wow, really exciting to think about having a vaccination for RSV. I think we've seen the impact of getting people vaccinated for COVID and what it can mean. And I just got back from my university setting, and just seeing the world reopening up is very much due to immunizations. So what I want to take you through is just some thoughts about, okay, we have the vaccine. Now, how do we get people to use it? And so just some practical strategies, tricks of the trade. And really the core here is motivation. It's all about behavior change. And I take a very theoretical approach to this. I use a couple of theories and models. One is the socio-ecological model, which looks at intrapersonal factors within the individual, maybe their beliefs, that kind of thing. Interpersonal factors, things that happen between individuals. The environment that either makes it easy or hard, and policies, such as required immunizations. And then self-efficacy theory, which really is around the interpersonal aspect. Actually performing a behavior makes us a lot more likely to do it. If you've gotten immunized before, you're going to be a lot more likely to do it again. Maybe, maybe not, if it was a positive experience. Verbal encouragement, being told to do it by somebody that you respect particularly. Role models, seeing others do it, and we've seen a lot of this used with regard to COVID. And most important for all individuals, but particularly for older adults, is removal of the unpleasant sensations, increasing the pleasant sensations, and increasing what we also refer to as outcome expectations, the belief that there will be a benefit if I do get immunized. So one of the best motivational techniques, in all honesty, or I'm going to put it this way, the easiest, is to make it law. Make it required. There's no choice, and that's the end of that. Or there's a choice to not work in the facility, not work in your position, whatever it is, but make it law. Making it accessible and free or cheap or covered is critical. Making immunizations visible, particularly if you're doing this in an institutional or community setting. Make sure they're out where they're easy for people to get to, not some deep, dark corner of the basement where it's hard for people to take the time to walk there and get it. Provide up-to-date and accurate information again and again and again, and we'll talk more about that. Make it positive. I'm not big on fear tactics. There's been a lot of evidence to show they don't work, but rather thinking about the reasons why people should get immunized. Have contests, which unit has the most employees or residents that are immunized, which floor in your building, whatever it is wherever it is you're working. De-implementing negative beliefs is really important. Getting rid of inaccurate information has to be done before you can get people to move forward. Identifying role models, if that's going to be helpful and relevant to your population. Being a role model and letting everybody know you got immunized. And then getting at the core of why somebody says no. And don't let people give you an excuse. I do a lot of motivation work related to exercise. And one of the biggest things is I don't have time to exercise. And I'm like, really? We all waste some time throughout the course of a day. And, tell me hour by hour what you actually do. But really getting to the core of what might be an excuse and what might be the real reason. Somebody might say, I don't have time. I don't know where to go. They might fess up and say they're afraid, but really finding out what really stops them. Some other practical strategies: make them easy to give, to get, and make it fun. If you don't have staff that can provide the vaccines, actually immunize people, you may want to partner with vaccine providers to hold vaccine clinics. Provide incentives for getting immunized. Give people T-shirts, a sticker, a mug. For some people, that's a useful incentive. Provide vaccines, as I said, in easily accessible areas at times when people can get there. For residents, we usually bring them to them. Incorporate vaccines into fun wellness fairs. Document and bill for vaccinations. Documentation of vaccinations in medical records and state immunization information systems is very helpful so that we can go back and access that information. Many states did a great job with COVID. We don't all do great jobs with many of the other immunizations we have. Provide residents and patients with vaccination certificates or give them to their families so that they can keep a record. It's really helpful. Most people don't know. Often we know that for children, but not adults. Train staff to administer and accurately bill, whether it's Medicare, Medicaid, whatever insurance plan the individuals have. Regardless of state guidelines, make immunizations required for residents within your facility. The facility has the ability to do that. I know it's a little tricky when there's emergency authorization only, but it is something that some facilities have gotten around within their states and done. And it is something we see very commonly with regard to flu. Every state does it a little different, both for staff and residents. Obtain ongoing consent for all relevant vaccines when people move in to a facility, whether it's assisted living, it could even be senior housing if you have a facility that gets that involved, or nursing homes. But get blanket consent so that you don't have to do it for every vaccine. We can then certainly let families know that the individual has been immunized, but you don't have to go through the whole consent process. Provide information to family and residents about inaccurate myths and updates on vaccines. And I personally often will do this with my medical director, get multiple voices on there, get all the credibility you can. Share credible sources, but provide that information. Use families and grandchildren, particularly babies, as the reason to get vaccinated. Many times older adults will do this for altruistic reasons. And get families to advocate for vaccines. They do a great job, and I had this particularly with shingles vaccines, where I got some families to just say, whoa, I want my mom and dad immunized. And I was able to bring in vaccines for shingles. Despite the cost, the facility actually covered some of the cost because families were pushing for it. You can address misconceptions using any resources you have and that are relevant for the population you're working with, whether it's videos, handouts. We're still very paper-oriented, I think, in the long-term care world. Particularly want to find things that are culturally relevant if it's important for your population. Educate staff about RSV and the issues for older adults, and create a competition, as I said, between units or facilities, giving prizes, just whoever's got the greatest percentage of patients or staff immunized. Identify unit or facility vaccination champions to get everybody really excited about vaccinations, to get them engaged, and to make it happen. And then it's also really important to publicize immunization rates to families. This can be important for admissions. Everybody wants others to go into facilities where it is known that the largest percentage of people have been immunized. And I get this question from families now, how many of your residents and how many of your staff have been immunized for COVID? So I use a very easy 5-step approach for implementing an immunization plan. Be or identify a champion, gather a team, establish the barriers and challenges, establish solutions, and make it happen. A champion is really just someone who's going to lead the effort. They're going to promote it. They're going to help with keeping records, finding out who's immunized, who's not, getting after them, and keeping all the documentation. Developing a team. It might be other office staff. It might be your director of nursing and assisted living manager, again, depending on where you are. But the team really must work together. Establish the barriers. Don't assume that you know. And really take some time and brainstorm. Ask, why are we not focused on immunizations here? Why can't we get our residents or staff immunized? What do they know? What do they believe? Where are our barriers? Is it because we're holding immunizations in the basement? And looking again, as I said, doing education anywhere, everywhere, repeatedly. Education doesn't change behavior, but it's a useful first step. Consider with the team solutions. Develop a plan for how you're going to overcome the barriers within your setting, within your community, within your practice. Barriers may be access for some and thinking about how you can bring immunizations to them. It might be staffing. You don't have anybody available to give it, so you're going to need to partner. It might be knowledge and belief. It might be fear and some big fear going through the facility for why somebody shouldn't get vaccinated. And then making it happen. It requires ongoing motivation. Never stop offering. If somebody says no to an immunization once, that's okay. Begin to work with them. As I said, find out what their barriers are and continue to try and overcome them. Work on ways to get rid of things like fear. Increase the benefit. Help people see why they should get immunized and think about benefit risk. And really, really try and decrease the unpleasant sensations and make it pleasant, make it fun, give that t-shirt, whatever it works, give that hug. I believe we can all do it. Don't respond to the clinical problems encountered, such as RSV, influenza, pneumonia, and shingles, but fight against them, really, with the best approaches we have. Take it on, be a champion for your older patients and the communities in which they live. I'm going to turn it back now to Taryn to lead us through some questions.
Great. Well, thank you very much for all of our presenters for an excellent presentation. We do have some questions, but I encourage all participants, if you have questions for our speakers, please write them in the question box and we will try to answer as many as we can. So the first question, it's a kind of a two-part question. I'll just pose both of them. RSV disease burden is not well known to healthcare providers. What recommendations do you have on how to share the importance with them, and who will be critical to share with? Is it primary care providers or geriatrics?
I would just say everybody is important to share with, both primary care providers, geriatrics, everybody, because I do agree, particularly with regard to older adults, it's not thought of as much.
Yeah, I think there's a lot of work to be done yet, right? I agree with the person asking the question that there just isn't a lot of knowledge among general providers out there about RSV in adults in general. And I think there's a reason for that. We haven't really had a lot of tools available to manage or treat it. So my experience in Lithuania 20 years ago was when they worked up respiratory infections, they didn't bother doing cultures or anything else because all they had available was a single drug. So everybody just got the single drug. They didn't bother doing the testing. So here we have a similar problem. So I think with Dr. Durham's presentation, there are things around the corner, but this is exactly the right time to start talking about RSV so that when those vaccines become available, if in fact they work as well as we hope they will, that they'll be prepared to reach for that and recommend them.
Great, thank you. Our next question is, do you think it will be important for an effective RSV treatment to be developed alongside adult vaccination?
I can start with that one. Yes, I think that is very important, especially for like our older adult population who acquire RSV and then have to be hospitalized and experience poor outcomes. Certainly, we would want to try to find appropriate treatments for that. There are treatments that have been looked at. I didn't go over those because we wanted the focus to be vaccinations, but things like ribavirin, have been looked at before. It just doesn't seem to be particularly effective against RSV. It's maybe a little bit effective, but in the clinical setting anyway, it doesn't seem to be, nearly as effective as we would like for it to be. So yes, I think definitely looking for treatments in addition to vaccines certainly would be very important.
Okay. Our next question is, since so many RSV vaccine trials have failed to protect despite good neutralizing antibody responses, what is the likelihood that neutralizing antibodies should or should not be the trial goal?
So again, I'll start with the answer to that one. I think that it is important to still look at our antibodies being produced, but the question makes a really excellent point. I think what it's getting at is if you're making antibodies, but it's not actually protecting against RSV, should you really look at the antibody production? I think we should, just because if you're not making any antibodies, it just wouldn't follow that you would be protected against RSV. So I do think we should look at that. But ultimately, the true question is, even if the vaccines are eliciting this antibody response, why are people not actually protected against RSV? And I think that there's not a clear answer to that at this point. So ultimately, yes, the final answer should really be, are patients protected against getting RSV? But I still think it's important to look at the antibody response.
Yeah, I think I'd like to add to that. I think you made an excellent point. Again, sort of harking back to influenza, the goal is, even though the ultimate goal would be to keep them from getting infected in the first place, like with influenza, like with the SARS-CoV-2 vaccines, really the goal is to keep them out of the hospital and keep them from getting sick. Neutralizing antibody only tells you part of the story, because there's a whole other set of the immune response, the T cells, that participate in recovery and keep them from getting as sick should they get infected and get breakthrough disease despite vaccination. So having neutralizing antibody as a benchmark, as a proxy for protection, I think is an incomplete solution. They need the clinical trials to back it up, and then probably it'll be more than one proxy for it.
Okay, thank you. Our next question is, do you think the COVID vaccine experience will make older adults more or less likely to accept RSV vaccination if and when available?
So I do think it will possibly have a positive effect for older adults. We may not be seeing the same thing for younger adults who seem to be the most resistant, but for the older adult community, I always tell the story. I had a patient that has always refused a flu shot because she swears the flu shot gave her arthritis, but she was right there in line to get a COVID vaccine. So I think it'll depend on how we roll things out, how it's presented, but I do think that there is increased awareness about the value of immunization. So hopefully it's more on people's minds.
Great. Okay. Our next question is, I think in the future, will Medicare and insurance be likely to cover the RSV vaccine for older patients?
I would hope that, they would, as long as, obviously the vaccines have to be approved. And if they show effectiveness, yes, we would certainly hope that things like Medicare and other insurance companies would support those. They do for, many other vaccines as well. So my hope would be that, yes, you would see that.
Yeah, it's probably going to be a sequence of events. They first get it licensed, and then the next step, the Advisory Committee on Immunization Practices has to decide what kind of recommendation they make, and then likely the insurance companies will follow based on whatever the strength of that recommendation is.
Okay, great. Well, I think that's it for our questions. Thank you very much to our faculty for that excellent presentation, and thanks to our listeners for joining in. As a reminder, to view the full educational program on the CCO website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.